Hereby I open this academic ceremony in which Ronel Sewpaul will defend the academic thesis, a tailored mHealth intervention for improving antenatal care seeking and its determinants among pregnant adolescent girls and young women in South Africa. May I invite you to present a summary of your study and the conclusions of your thesis.
Dear Pro-Rector, members of the Defense Committee, family, friends, colleagues, online, and here in the aula. For the next 15 minutes, I'm going to present the results of my PhD research. The research was centered around a study called Teen Mom Connect that developed and evaluated a mobile health intervention that was designed to improve antenatal care seeking and its determinants, as well as general health behaviors during pregnancy, among adolescent girls and young women. The study was conducted in Cape Town, South Africa, during 2016 to 2019. And when we talk about antenatal care, we're speaking about the prenatal visits that pregnant women attend throughout the course of pregnancy, where they receive health promotion and health education, and they also receive medical tests that are used to prevent, detect, and manage complications of pregnancy. Just to provide an outline, the first part of the research focused on understanding the experiences of pregnant women attending antenatal care in Cape Town, South Africa, and then looked at their psychosocial determinants of wanting to, or the intention, and being confident enough to, or self-efficacy, to attend antenatal care. The second half looked at describing the development and the evaluation of the Teen Mom Connect intervention. Just to provide a context before getting into what was done in the study, teenage pregnancy is quite high in South Africa, where about 16% of adolescent girls and young women have begun childbearing. Teenage pregnancy is more common in the lower socioeconomic areas of the country. Adolescent girls and young women are at increased risk of pregnancy complications. They also have higher maternal and infant mortality rates compared to adult women. They also have higher rates of substance use. Pregnant adolescent girls and young women often lack the knowledge of how to appropriately care for themselves. They're usually psychologically and physiologically less prepared compared to older adult women. Adolescent girls and young women, in addition, tend to have lower antenatal care attendance. In South Africa, where antenatal care is provided free of cost at all public health facilities, 77% of adolescent girls and young women attend the WHO requisite of at least 4 visits. And some tend to book in late for their antenatal care, while some even attend antenatal care when they're in labor. Pregnancy outcomes can be improved by timely and regular antenatal care and by practicing good health behaviors. Mobile health interventions have been applied in a wide range of public health domains, including in maternal health. They have been shown to increase antenatal care in low and middle income countries, and in these countries they're largely SMS-based. The reason for this is that in these countries, as well as in South Africa, there is large mobile phone coverage, but smartphone coverage, especially at the time of development in 2017, was rather low, or relatively low compared to high-income countries. In addition, there are high data costs, mobile data costs, as well as poor coverage in certain areas, and therefore SMS is generally preferred in low and middle income countries such as South Africa. Mom Connect is a national mobile health intervention, and it is routinely present in South Africa, where pregnant women arrive at a clinic and they're routinely registered onto the Mom Connect platform. They then receive maternal health SMSs along the different stages of their pregnancy until the child is 1 year old. However, it's unclear how Mom Connect performs for adolescent girls and young women because they have higher odds of opting out of the program compared to adult women. The behavioral, cognitive, and motivational needs are different for adolescent girls and young women compared to older adult women, and therefore we thought of adapting the Mom Connect intervention for adolescent girls and young women so that we tailor it and target it to the specific age group, and we thought that that might induce greater behavioral change. Moving on to looking at the experiences and the drivers of antenatal attendance among adolescent girls and young women, which was part 1. We first conducted formative qualitative research prior to intervention development, and this was done during mid-2017, where we interviewed about 19 pregnant adolescent girls and young women aged 13 to 19 years old who were already attending antenatal care services in Cape Town. We asked them to participate in either in-depth interviews or mini focus group discussions. We found for one particular theme that was experiences that reinforce antenatal clinic attendance, which were respectful and supportive treatment. And quotes in support of these are that some nurses are nice to you, they show you respect, they're always helpful, talk to you, ask you questions, treat you with love and respect. They made me feel welcome. Another quote in support of this was that they will come and tell you it's just you and me here. There's no one else here, and whatever you ask me will stay between us. However, these positive experiences were far outweighed by negative experiences that discouraged antenatal clinic attendance, and these fell into 6 main thematic areas, which were victimization, discrimination against being pregnant during the teenage years, and experiencing disregard and exclusion. Some quotes in support of this were, if you're young, they are nasty to you. They say negative things about the fact that you are young and pregnant, even go as far as telling others to look at you, saying, look at this one, pregnant at this age. Other themes were inadequate provision of information about pregnancy, health, and childbirth. A quote in support of this is, they seem so unapproachable that you feel scared to ask questions. The other themes were clinic attendance, discouragement and alienation, and mental health turmoil. For example, it hurts a lot. You expect that you will get help and get support, while the very people that you trust to give you information are rude to you, and it's discouraging. For the next study, we interviewed the adolescent girls and young women who were recruited to participate in the interventions trial, and we looked at the psychosocial determinants of wanting to and being confident enough to attend their appointments. We found that determinants that increased intention and self-efficacy were risk perceptions and the attitudes of family, peers, partners, and the participants themselves. The family, peer, partner, and participant attitudes were very strongly reported in that the majority of participants reported having positive family, peer, participant, and partner attitudes towards attending appointments, with very few negative attitudes being reported. And these attitudes were quite strongly associated with intention and self-efficacy. When we look at relevance for behavior change interventions, we're looking at items that are not that commonly reported. So they have middle to low average scores, but they're still associated with intention and self-efficacy. And these particular items that we found that were relevant were the perceived risk of experiencing complications like preeclampsia, which is characterized by high blood pressure, as well as heavy bleeding if appointments are not attended. And therefore, if we were to use or develop interventions, these would be relevant risk items to target for this population group. The next part looks at the development and evaluation of the intervention. As I was saying, Mom Connect is an existing maternal health program in South Africa, where women are routinely registered when they come to the clinic. The nurse confirms their pregnancy. The nurse then assists them to register with their mobile phone onto the Mom Connect platform. Their pregnancy is then registered onto a central Department of Health database, and from there on they receive SMS messages up to the time that the child is 1 year old. The development of the intervention Teen Mom Connect took place during June 2017 to February 2018. And the content that informed the development was we conducted interviews with pregnant adolescent girls and young women, as mentioned earlier, where we also assessed their feedback on the Mom Connect messages. We pre-tested draft messages. We also conducted a review of the factors that are associated with teenage pregnancy and antenatal care. We reviewed maternal health education resources from the clinics and from the Department of Health, and we also reviewed the existing Mom Connect messages. We developed a message library that contained messages from 13 behavioral domains, and these fell into the areas of appointment keeping, which was a primary outcome, general health information and clinic attendance, social variables like attitude towards pregnancy, social stigma, social support, infections like sexually transmitted diseases, tuberculosis. Then there was nutrition and self-care, and also substance use items like alcohol, smoking, and illegal drugs. When we compare the Teen Mom Connect to the Mom Connect had fixed messages, one-way SMSs that were tailored along the stages of pregnancy. The Teen Mom Connect was designed to send motivational and behavioral messages that were tailored by pregnancy and join week. Join week because if a participant joined late, they would then receive catch-up messages that were relevant from the weeks that they had missed. There was also tailored two-way message feedback where a participant would then respond to a question with a closed-ended response, and then they would receive tailored feedback based on whatever response they submitted. There was also a face-to-face motivational interviewing session that they received with a research assistant during the course of their pregnancy. Examples of messages on smoking are shown up there. For example, a participant would receive a message saying, during the past month, on how many days did you smoke cigarettes? Reply with A, B, or C. Where A was 0, B and C were 1 to 15 days or 15 to 30 days. And if they said they did not smoke, then they would get a message that said, well done, by not smoking during pregnancy, you will have much lower chances of having a low birth weight baby. If they did report that they smoked on any of the days, they received a message saying, it can be hard to give up smoking, but it is one of the most important things that you can do for a healthy pregnancy and healthy delivery. The messages on appointment attendance were iterative two-way tailored messages that were sent every 4 weeks for participants who either did or did not know when their next pregnancy date was. They would also receive checkups that the appointments were attended, and if they were not, then they would receive tailored feedback on the various reasons for not attending the appointment. The Teen Mom Connect intervention was evaluated using a pilot randomized controlled trial design, where we had just over 600 participants that were assessed for eligibility at baseline. They could not be registered into the intervention if they were already registered onto Mom Connect, and if they had missing information that was required to be input into the registration program. And therefore, we were able to randomize 412 participants to the Mom Connect intervention or the Teen Mom Connect intervention. The Mom Connect intervention received the standard one-way SMSs, while the Teen Mom Connect received the two-way tailored messages supplemented with motivational interviewing. And at the end of the pregnancy, all groups completed a post-test survey, and we also retrieved the patient records of participants to assess the number of appointments that they attended. The primary outcomes measured in this trial were the number of appointments attended, as well as user acceptability of the intervention. In terms of user acceptability, a very high proportion, 84%, rated the content or the message content highly in terms of its value. And 72% rated the messages highly in terms of their motivational nature for behavior change. Engagement was very, very low though, where participants responded to an average of 20% of the two-way messages that they received. In terms of behavioral outcomes for average appointment attendance, this did not differ significantly between the Mom Connect control group and the Teen Mom Connect intervention group. However, average appointment attendance was higher in the intervention group that received motivational interviewing compared to the control group. It was also higher among the intervention group participants who responded to more than 50% of messages, or the high responders, compared to the control group participants. But neither of these two findings were statistically significant. We did find that the increase in knowledge scores was higher among the intervention group high responders compared to the control group, and this was statistically significant. Therefore, the intervention was helpful in improving knowledge in those who interacted more with it. To discuss the findings, we find that the low engagement with the two-way messaging could have impacted the outcomes. Perhaps the messages were not motivating enough, or they did not sufficiently target the constructs that affect antenatal attendance behavior. Perhaps a higher dose of or intensity was needed, and maybe a more interpersonal or intensive intervention was needed to change appointment attendance. We did face various challenges that included that pregnant girls, about a fifth of them in fact, had changed their mobile phone numbers or SIM cards during the course of the study, which affected their exposure to the intervention. There was also difficulty in tracking and tracing participants and in accessing patient records at the health facilities. Nevertheless, the study lays a foundation for future research directions, especially as technology has progressed since then, and we now have apps, WhatsApp, chatbots that allow us to incorporate far more features than an SMS platform could. Thank you for listening, and I now give the word back to the prorector.
Thank you for this introduction. The opposition will now be opened by Professor Kroon, Professor of Health Promotion, Prevention and Care at this university. Professor Kroon was also the chair of the assessment committee.
Dear candidate, my compliments to you and to your supervisors, of course. You've written a really interesting dissertation on an important topic, and it's also a topic that I'm involved with, but in a totally different way. I'm also involved with group care in antenatal care. You already heard from it. It's also in Cape Town, actually. And before I start with my question, I have one question. I was just looking at the front of your dissertation, and I think it's really beautiful, but could you maybe explain what's the idea behind it? Yeah.
Highly esteemed opponent, thank you for the compliments and thank you for the question, which I'm looking forward to answering. The cover was actually, a friend of mine was pregnant at the time, and she had this cover of a stylized image of a pregnant woman, and I decided to adapt that and draw it slightly differently to make it look like a South African teenage woman or girl. And so I did that, and then I felt like teenage pregnancy is such a confusing time, and there's so much stigma that a pregnant woman would face during this time. There is also a lot of confusion and can feel like you're in a maze. So it was like, oh, well, what will help me get out of this maze? What will empower me to break out of this maze? And it was like mobile health kind of does that. It does provide an opportunity for you to get access to healthcare information that will help you sort of break out of the maze. And hence the idea of the woman holding a phone, breaking out of the maze.
Okay, I understand. So that's a really interesting image. I can connect with that. But nevertheless, now I have some question, because it must be frustrating to not finding a difference in attendance. Well, you have consciously adapted. So after reading your dissertation, the question remained in my head why the adaptation of Mom Connect was needed, actually. Because Mom Connect has shown an impact on attendance. And actually the main reasons for that you would want to adapt it is because the young women opt out or maybe drop out during it. But that's not the same as not attending. So why would you assume that the attendance effects would have been different if you have adapted it? And so why is actually the reason for making all this adaptation, and was it really needed afterwards? Yeah.
Thank you for that question. Yes, I grappled with that answer myself and with my supervisors. In terms of adaptation, we felt that tailoring and adapting to something for pregnant or any specific subpopulation is always necessary because each one's needs are so different. With adolescent girls and young women, their needs are very uniquely different compared to adult women. Their risks are higher, but also their knowledge is lower, they lack the preparedness, their mindset, their cognitive, their motivational needs are all very, very different to older women. And therefore, we knew that attendance was low. This was a problem that we needed to intervene upon. And we were thinking how best we could intervene upon this. And in terms of the literature and what's out there, we know that adapting and tailoring as much as possible to each unique individual and moving towards personalized medicine is the way to go in terms of inducing behavior change. And that's why we felt like we wanted to adapt it. However, we did see that, yes, the odds of opting out of Mom Connect are lower for adolescent girls and young women. And in this study, we saw that the engagement with the two-way messaging is low.
Yeah.
So, yes, the question is still relevant. Why do we need to adapt it? But then I bring it back to, I think that moving towards personalized medicine, there is a need to tailor.
But I was wondering, but why didn't you then use Mom Connect, because I understood, I saw a paper on how often is used Mom Connect, and it's impressive how many women in South Africa use Mom Connect. So why not actually use Mom Connect and then see whether you can introduce tailoring in that and personalize it in the actual Mom Connect?
That would be why we didn't do it at the time. Was we had consultations with the Department of Health, and we pitched it as something that was specifically targeted for adolescents with an increased level of tailoring. And the novelty of it would be the two-way messages. In terms of technical abilities of what Mom Connect could do at the time, we had a conversation with the technical implementer, and they were not able to, at the time, incorporate two-way messages for the whole population and integrate that into Mom Connect as it was at the time. And so therefore we proposed this, and we first proposed it as either a WhatsApp chatbot or as an app. And then we had discussions with the technical implementer and with the Department of Health, and they said that no, SMSs are relevant. See what you can do within an SMS, because that is relevant to the country right now. Let's not move to apps and WhatsApp just yet. And so we looked at within an SMS, what can we do? And the most amount of tailoring that we could incorporate at the time was to get back and forth two-way tailoring. And that was the novelty, and that was why we looked at comparing it. But now that technology has changed so much over time.
So you would connect, yes.
Yeah, Mom Connect has itself moved to WhatsApp. Yeah. And it's incorporated much longer messages. So now in the future, we could partner again with them and say, can we incorporate some of these behavioral change messages that are designed for adolescent girls and young women?
Because I have still 1 minute left, I think. So,
sorry,
but I have a really important question still. But then remains the question that maybe they won't engage. They won't opt in and other things. So I was wondering, is Mom Connect, shouldn't be integrated with other things? And shouldn't it be something that, because you're not this group of vulnerable women in vulnerable situations, it seems that they are not so willing to actually engage or start uptake with Mom Connect. So wouldn't it be better to integrate it with other activities and see whether you can make them actually improve the engagers and make them engage more? Because you had this motivational interviewing, and motivational interviewing seems to somehow work, but even then it's difficult to engage. So isn't it time to reflect on how you actually can engage them?
Yes, I think that we can definitely, we need to improve engagement. In all the studies across the world, we're finding that engagement for adolescents is low in mobile health interventions, but yet mobile health interventions appeal to them. So I think it would involve a discussion with all the key partners involved and seeing what is actually possible, what will work for adolescents in this particular setting, what appeals to them, and how can we integrate the mHealth component into what's existing in the current health setting. Maybe, although it is already being done, when they arrive at the clinic, they are being presented with the option, hey, let's enroll you onto an mHealth system.
Yeah,
so I'm not sure how much more.
I have an idea.
Yes.
Yeah?
Please.
So maybe we can discuss this later. I'm thinking about this group care component, and maybe we can integrate Mom Connect with that, so that there you have this social connection, and then maybe you can use Mom Connect to an extra connection within this group care. So that, I think that would be maybe an interesting option to look at.
That would be amazing. Thank you.
So, that would be really, that's my idea, actually.
Yeah. Thank you so much.
Thank you.
Thank you. The opposition will be continued by Dr. Onoya, Principal Researcher at the Health Economics and Epidemiology Research Office in Johannesburg. Dr. Onoya was also a member of the assessment committee, and we highly appreciate your participation to this academic ceremony.
Thank you so much for the opportunity to participate. Here is always a bit of a mouthful when you have to say it completely. But dear candidate, thank you so much for this impressive body of work that you have put together. It's easy to critique, once the work is done and you start to pick at it. But when you think about implementing a series of studies that try to address such a complex problem in South Africa, it is a very different exercise. So congratulations on completing that and putting that forward for your PhD. I had a couple of issues that often come up when we talk about. I generally, every time I see a study that says patients are having negative experiences at facilities and the nurses are doing X, Y, and Z, and then we try to develop an intervention that address the patient side of the equation, I feel almost there's a missed opportunity in engaging the full sort of spectrum of stakeholders in the solution. So I wanted to hear a little bit from you about your thoughts on the contribution of healthcare workers in resolving the engagement of teenage pregnant young women, in antenatal care, and the extent to which an intervention such as Mom Connect can actually support, that solution that includes them as well.
Highly esteemed opponent, thank you for the questions and thank you so much for your compliments. In terms of the healthcare workers, I think we do need to, when we're reporting negative attitudes that pregnant women are saying that the healthcare workers have, we also need to look at the opposite end of it and get the perspective of the healthcare workers themselves. We didn't do that directly in this study, but there's a wealth of literature that has looked into that. And what they found is that the healthcare workers are also quite heavily burdened. They also have resource constraints. They might have different values that might disapprove or not be hesitant to provide sexual and reproductive healthcare services to adolescents because of their own disagreements and values. And they might think that the adolescents themselves might be rude towards them. There's all these different perspectives, and I think it involves a discussion with all the key players. And this includes the Department of Health, but going down to provincial and then district levels in the department and fully engaging with these healthcare workers. I think that what is currently happening in South Africa is the National Adolescent Friendly Clinic Initiative, which at the time of the study, when the data was collected, was not that well implemented. But it seems that since then, in certain parts of the country, it is now very well implemented in some clinics in South Africa. And these can be used, I think, as a model for care. We can then partner together with the healthcare workers. And why this is successful, these NAFCI clinics, is because the nurses and the midwives undergo regular refresher training courses, and they also receive reinforcement, and the quality of their services monitored. They're also able to provide specialized care for adolescents in youth zones. And youth zones are specialized times and hours and even spaces in clinics that are dedicated for youth. And these have shown positive findings on both the youth and the healthcare workers. And I think if we use this as a model to go forward, then there's, and bring in the stakeholders at various levels, maybe some public-private partnerships, we can then move forward and see how that would work, and how that would involve Mom Connect at this, bringing in the mHealth component as well as the actual face-to-face delivery of healthcare, and seeing how that can function together with suggestions like group antenatal care, which have been piloted in South Africa and which have also been shown promise. Yeah, it would involve a roundtable discussion of how we can integrate all of these things and still not overburden the healthcare workers, which is clearly happening. Thank you.
No, thanks for that. Maybe I can pick on you, because you're probably closer to this literature than I am. Recently, a Nurse Connect tool has come up to try to sort of bridge the gap. I don't know if you have some thoughts about whether or not that does begin to address some of these challenges.
I don't know to what extent it has begun addressing the challenges, but I do know that it is quite advocated for by the Department of Health, that nurses enroll onto Nurse Connect and start using it. I'm not fully familiar with its platform and how much success it has, but I think, again, it would be dependent, as all mHealth is, on engagement and how willing the nurse is to be involved in the mHealth component of it. But yes, it definitely has potential for being something that can complement their actual workload while they're at work, and maybe in the comfort of their homes while they're looking after their busy day at what they can do to better improve their provision of care. I'm not.
I don't know how much more time I have, and I just have one more question. I find that in adaptations of interventions, the more we adapt, the more modular the intervention does become. Already your adaptation includes a SMS-only messages that are adapted to teens. Then you have an interactive two-way communication part of the tool, and then you have the motivational interviewing sessions that the teenagers attended. And I wondered if you're able to reflect a little bit on, if you had to pick one, which one do you think you would prefer, and perhaps why? What aspect of this problem does it best address?
If I had to pick one, which is very hard to do given what we know in the thesis and the limited findings, sample sizes, etc., then I think I would pick the two-way tailoring component, but provided I was able to extend that way further and go to much more increased levels of tailoring that are now possible, and that go beyond SMS, that go into WhatsApp, things like, even using generative AI to get something that's way more precise and way more tailored to an individual, looking at, what their fears are, what their attitudes to something specific are, what their underlying beliefs are to something, and tailoring it, and even tailoring to what their barriers to antenatal appointment attendance may be, whether it may be transport, maybe it might be financial, living too far away, specifically tailoring it to each of those things. So for me, yes, the tailoring part and the two-way messages part, but provided I could extend that, way more.
Thank you so much. And that's those are the questions I had for now.
The opposition will be continued by Professor Sifunda, Chief Research Director in the Human and Social Capabilities at the Human Sciences Research Council in South Africa. Professor Sifunda was also member of the assessment committee, and thank you for coming over for this academic ceremony.
Dear candidate, first of all, let me congratulate you on taking this task of doing this work. It is really, really important work in South Africa. There's a lot of people who claim to be doing it while they're doing it. But none of them are brave enough to do what you did. They produce a series of surveys, lots of them, and they print them. And then they don't go beyond that. They just say, we did a survey, and this is what we found. We don't even know what to do about it. Because what you've done is you've actually moved further than what most people do to go into really testing this intervention that's very specific to young people. And yeah, congratulations for that. It is a brave and really, really important work that you did. And I just want to go into, some of what I have here. You've actually answered it. You preempted me. But just to say, the technology has moved a lot, as you said in your presentation. In the last 5 years, there is TikTok, which I don't know what it is, but my kids know it. but the technology itself, as you say, is much more advanced. USSD actually has been dumped by even the banks and the cell phone companies themselves, and they're using WhatsApp to talk to their customers. So it's actually a technology that's almost dead, but you used it very well to actually do this important work. So with all these advances, as I said, in the past, WhatsApp could only chat one-on-one. Now you can chat with 100 people. So there's a lot that has moved since you did the work. And so my question really is to just say to you, if you reflect on these things like AI being embedded into the program, where someone can even ask a question and they get an immediate answer, and then almost chatting back with AI, do you think would improve this type of programs going into the future?
Highly esteemed opponent, thank you for the compliments and thank you for the question. If I'm understanding correctly, you're asking if the receiving responses by AI would improve things in the future. I wasn't hearing it too well.
Yeah, because what SMS does, as you said, you send a message, maybe you get a response, but the new technologies, the response is instant. Even WhatsApp, as I said, it was useless when it started. Now it's doing a whole lot of things, and that's why cell phone companies and banks and everyone is actually using WhatsApp technology. Mm-hmm. And they've dumped their own technology because they believe it does better. So it's along those lines that I'm asking the question.
Thank you for the question. Yes, I think WhatsApp allows us to do much more than one- and two-way SMSs. Mom Connect, as I was saying, has expanded to a WhatsApp platform, and this, most importantly, allows us to send a much longer SMS or much longer message than the 160 characters that you're limited to with an SMS. So therefore, you can have quite a lot of content that's included in one single SMS. Before, you'd be restricted to just keeping it to exactly what you wanted to say and a specific topic, whereas now you can build onto that topic. And you can include a little bit of entertainment or a little bit of a link. And usually you can get a link, and then if you click on that link, it then will take you to a website where you can access further content about that. It can also, the chatbot features in WhatsApp are quite extensive actually. So it can incorporate back and forth messaging and layering of messaging, iterative messaging throughout different stages of pregnancy or whatever the public health area may be. So I think that with WhatsApp specifically, there is a large wealth of things that we can build into. I'm not sure if you can build some generative AI into the back-end programming of WhatsApp, but I think it may be possible, and with that, I mean, the opportunities are endless for precision and for tailoring to whatever you may be answering a question about. I think I'm going to stop there. I'm not sure if I sufficiently answered the question.
Yes, you have. Thank you. So in a way, would you, in your future engagements with the Department of Health, strongly recommend that they implement some of these ideas that you have thought about, and to improve, as you said in the beginning, you couldn't do this on WhatsApp. That's why it was SMS based, and they've moved now to WhatsApp, and chances are they are not using all the capabilities of the platform that I think are possible.
Yes, definitely. I think it would be very valuable to have a conversation with the implementing partners of Mom Connect and with the Department of Health. And now that we actually have the papers published and have what's really readily available and what we found, it would be good to go to them and say that currently Mum Connect is using a WhatsApp platform, it is using longer messages, and it is having a certain amount of tailoring. But for a specific age group, that is adolescent girls and young women, we have something that is very relevant. We would like to incorporate that into your messaging and explore ways of doing that, but not just our messaging in general, but going further and making that more, having more function and more tailoring and back and forth messages that we can do. And the advantage is that our messages were developed, they're quite theory-based, and that is obviously, the literature shows that messages that are theory-based have increased, usually they lead to desired behavioral outcomes, much more than those that are not theory-based. So we do have all of those advantages, and yes, it would be beneficial to go to them and say, what can we do to incorporate what we know about Team Mom Connect and its usability, its acceptability, even the engagement rates, which are, even though they were low, it's a finding in itself. And all of that provides information that we can use to tailor something for the adolescent girl and young woman group. And why that would be important for the Department of Health is, as I said, because adolescent pregnancy is so high in the country, it is a priority area, and that's why they would take an interest. Thank you.
Just a quick last one from me, I think, for a minute. It's now outside. In South Africa, there's this debate about the impact of the child grant on whether teenagers get pregnant or not. Some say the grant does not make teenagers to get pregnant, and they have evidence. Others say it doesn't, and they also have evidence. So there's this divide. Those who don't want the grant, they say we've got evidence that it does make kids get pregnant. Those who are pro-grant, they say, no, you're lying. Our evidence says it doesn't. I just want you to reflect on that. What are your thoughts? Quickly.
Quickly. Yes. In general, yes, there is mixed evidence. So we're relying on the evidence that's available. I won't fully be able to comment on that because I didn't really look at the child support grant, within the scope of this research. The evidence is there. I mean, financial support is economically speaking, it's incentive to do many things. In South Africa, maybe yes, maybe no. And I think I'm going to leave it at that. Again, I can't fully comment.
Thanks.
Sorry about that.
Thank you.
The opposition will be continued by Professor Ruiter, Professor of Health and Social Psychology at this university. Professor Ruiter is also a member of the Assessment Committee and the Secretary of the Degree Committee.
Thank you, Mr. Pro-Rector. Dear candidate, as they say, we go back already a long time, and really a long time. And I think since the start I met you, I was impressed by the quality of work you do, the intelligence you have, etc. It's also clearly visible in the presentation, the clear presentation. Very nice to listen to you. And I was urging you to start a PhD. And you never did. So, no, I'm not ready for it. And I said, why not? Just do it. You have the capabilities. No. And then at some point you said yes. So I'm more than very happy to see that you're now here and defending this work for a PhD degree. And I would also like to compliment you on the work you did, the quality of it, because I really have not much to add to the quality of the studies. I mean, that in general is very good. Published everything, so that's a great compliment to you, but also to your team of supervisors. I think you have an excellent team there. So my compliments. I do want to go into some detail because it was in the manuscript on page 81, but I now looked it up. Figure 1 on page 91. You know that page? No? Do you have a book in front of you? Yeah? Maybe go to that figure. Figure 1, page 91. Yeah. I had a surprise there when I looked at this graph. And do you guess what my surprise is?
Not yet.
Not yet. I was immediately attracted to the control group, experimental group. And then I read what's in the control group and experimental group. And then I see that in the control group, there's Mom Connect. And in the intervention group, there is Teen Mom Connect that has two branches, well, two elements, SMS, two-way, active learning, always better than passive learning, yes. And, but also motivational interview. Do you now see my surprise? What the surprise is that I thought, where is the third condition? Because if you now find the difference between the experimental and control group, where do you attribute the difference to? Well, you didn't find an effect, a significant effect. I think still the difference you saw in percentage is quite huge, but you had a relatively low sample size. But that difference, if it would have been significant, you would have to explain it. You would say, well, exposure to Teen Mom has done better than exposure to the Mom Connect. But I would ask myself the question, is it the SMS? Is it the motivational interview? So is there not a need for a third condition? And then if I go one chapter further, then I see in the participants and study design that then you say, okay, a subset of the sample received a motivational interview element. And I was wondering, because I couldn't really find it back, what happened with that subset. I didn't see it really back in the analysis. So could you inform me a bit more about that?
Highly esteemed opponent, thank you for the compliments. Thank you for the question. Yes, the motivational interviewing session was incorporated into the intervention because we were testing. It was a pilot study and we were testing various things. First, we weren't not sure at the time whether we could recruit enough pregnant women and girls to be able to conduct a three-way trial, which would have been perfect, where the one received Mom Connect, the second, the Teen Mom Connect, and then maybe the third, the Teen Mom Connect, plus the MI. But it so happened that along the way, we found that implementing MI was much harder than we thought, than we expected. Firstly, we wanted the MI to be implemented by healthcare workers, and when we approached them and the Department of Health, it was found that this was not possible because they could not incorporate it into their already busy schedules. And so this had to be implemented by a research assistant. And then we found that when we tried to schedule the MI sessions, it was quite difficult to actually get the participants to be free at a certain time, and a lot of them made appointments and then canceled them, or continued to turn down appointments. And then we were running out of time before the end of their pregnancy. And therefore we were able to conduct one MI session, and we realized as we were going along that a lot of participants were not going to get an MI session. And therefore we decided to adjust the design a little bit, where we said that let us try to get a 30% subsample of participants who would receive MI, and those would be the ones that we'd be able to, who would be able to interview and administer an MI session to during the course of their pregnancy. And so that's what we achieved, was a 30% subsample, which I think was about 64 participants out of the total intervention group. And this then allowed us to look at sort of a not a dose response analysis, but a separate analysis that kind of created a third arm in a way, because it allowed us to look at the control and then the Teen Mom Connect without the MI, and then the Teen Mom Connect with the MI. So in a way, it allowed us to do what we wanted to do in the beginning, but with much lower sample size, and that for the group that received MI, and had their appointments measured, for whom we were able to retrieve participant records, this then limited our power to be able to detect a significant effect. So we did find...
you observe some effect, even if you could not statistically test it?
Yes, we did observe an effect. I think it was mentioned in one of the slides. It was quite a high effect of about, I think, 0.37 effect size, which is quite large, and it was just a little short of our intended effect size of 0.4, but quite large. And I think it was to do a lot with the lower sample size. We had a higher number of participants who received MI and the intervention versus did not receive MI and control. Perhaps that would have been statistically significant.
Okay. I also hear that I missed out something on reading, but sorry for that. But in general, if you look back, and we know you have not been fully involved in the development of the intervention in the sense that it already happened in 2016, so it's also a bit... how do you look at the development process of this intervention? Where do you see room for improvement? Where would have to be in that room? I hear already one, that's anticipating implementation. In this sense that, okay, motivation interviewing was the plan, but didn't work out because of lack of time, etc. So are there other elements that you think, well, if you just look at the development process of the intervention, where would you improve it?
There are definitely elements that I could have improved. Now that I know what I know, many years later, I've attended an intervention mapping course a few years ago.
I was hoping you would not say intervention mapping. Then it's too obvious.
Too obvious. So I attended an intervention mapping course, so I know a lot about that. And since intervention mapping, there are other strategies out there. A common one is the COM-B approach, the capabilities, opportunities, motivation, behavior approach, and all of those provide frameworks. So I would apply one or more of those frameworks to the message development, where I would then look at attendance behavior, and then it has sub-behaviors. So getting yourself to the clinic and attending has sub-behaviors. It has transporting yourself there, it has being willing to go there, it has facing the nurses, and each of those sub-behaviors can be, with these intervention mapping matrices or COM-B matrices, you can then map those sub-behaviors to what are the determinants of each of those, and then what are the underlying beliefs of each of those, and then what kind of messages would target each of those beliefs, and then even go further at evaluating that at the end.
No, that's fully right, and that shows a good understanding of these things. I would also suggest, and that goes back to the first questions, to have a better look at the environment. There we see the equation, the formula there, the equation there, and both sides, that needs attention. But I hope if you use one or more frameworks, intervention mapping is part of it. Thank you very much.
Thank you. The opposition will be continued by Dr. Bruinsma, Assistant Professor at the Department of Health Promotion at this university.
Dear candidate, similar like the other opponents, I'm happy to congratulate you with this amazing piece of work that is in front of me. I think it's very well structured. It includes qualitative work. It includes a questionnaire study where you used R to analyze, and it includes a RCT that you conducted on multiple centers, which is quite a challenge, I know. But I think it demonstrates really nicely that you have a very diverse skill as a researcher. So you can be very proud on this. And in that, congratulations. I, of course, also want to include your supervisory team. Well done supervising this thesis. I'm not only here to ask you questions, and we're running a bit out of time, so I'm going to jump immediately to chapter 3, where you conducted a questionnaire study. And I noticed there that you included mainly intentions and self-efficacies as the outcome variables. So it made me wonder a bit why you ignored the behavior as an outcome, because the determinants included in these models, they are eventually about the behavior. So can you maybe guide me a little bit through that decisional process of focusing on intention and self-efficacy?
Highly esteemed opponent, thank you for the questions, thank you for the compliment. What guided the decision of what to use is what was available in the baseline data. At the baseline survey was conducted upon recruitment, which was usually the first or maybe second antenatal appointment that the woman was attending. And at that point, we didn't have any behavioral data. So the most closest determinant to the actual behavior was the intention and then the self-efficacy. And those were the most higher order determinants, and then we looked at the lower order determinants.
Okay, that's a reasonable decision. If you don't have the data, you cannot use it. But these intention and self-efficacy were quite high already. And that was also a bit of a surprise to me, because I first read chapter 2, and there I found out there's quite some barriers. A lot of the participants, they felt stigmatized, they didn't felt treated with respect, which is, to me, was quite surprised that they had this high level of motivation. So I wondered a little bit, okay, how does that work? They either feel treated unrespectful, but still go because they are very highly motivated, or you only included there a sample of highly motivated individuals. Could that also be the case? What's your thought on this?
Thank you for the question. Yes, I was also myself surprised by why intention was so high, self-efficacy was so high, but yet we know from the literature, and now that we follow these individuals up over time, we know that their behavior is actually not desirable. So it could be that at baseline they reported what was socially desirable answers. It could also be that there was this intention behavior gap, and though they might have said, yes, I want to attend my appointments, I'm intending to, I feel confident to, but yet when it actually came to doing the behavior, they didn't actually enact the behavior. And so there's an intention behavior gap, because there are obviously other factors besides just being willing and wanting to and feeling confident to that affect actually getting to the clinic, but not just attending one appointment, attending all of them or enough of the appointments. And these other factors could be financial costs to attend, being able to negotiate with their families, or having the autonomy in their decision-making to be able to say they should go, and taking charge of their health and getting themselves to the actual appointment every single time and on time and routinely and early enough as well. So there are these other factors: cost, economics, conflicting family, living far away from the clinic, quite a few other factors that will bridge this intention behavior gap.
Yeah. And you also mentioned earlier in the discussion that it was very difficult to find participants for these motivational interviewing sessions. I think that's also a good reflection that it's very difficult. I'm still a bit surprised that it's not reflected in that self-efficacy scale, because that was also quite high. And the things that you mentioned, having time, going there, have to travel long distance, they also fit a little bit within that self-efficacy scale, I would say. I also noticed in this questionnaire study, I think the development process was very well. You designed it very good in triangulation with literature and theory. You even developed this backwards translated versions of these questionnaires. And I thought, wow, this is very nice to see. It was available in English, Afrikaans, and please excuse me if I pronounce it wrong, isiXhosa?
isiXhosa, yeah.
isiXhosa. But I was a bit surprised. Only 2 out of the 575 participants opted for these local language specific versions. While in the earlier qualitative study, the majority actually spoke isiXhosa. Do you have an explanation for this? I thought it's a big difference.
We also didn't expect that, but what we find in quite a lot of the public health studies that we do outside of the study is that in South Africa, we have 11 official languages, and in Cape Town, the majority of the languages spoken are isiXhosa, Afrikaans, and English. But when it comes to actually administering surveys, and when we ask what option would you like to choose to conduct, to receive your survey, or a lot of participants actually choose English. So I think we had English 65% for administering the questionnaire, and also for receiving the messages. Quite a high proportion chose English, and this could perhaps be the nature of messages. They're used to receiving messages maybe in English, and yes.
Ronel Sewpaul, the time appointed for defending your thesis has passed. The degree committee will now withdraw to discuss the quality of your thesis and your defense. I request that you and your company await the results of our deliberations and our return in this room.
The PhD defense has now ended. The degree committee will debate the candidate's performance behind closed doors. This process usually takes about 10 minutes.
Long road to the south side, 7 miles in my rearview mirror. I know what it felt like. My goals only getting clearer. East side to the west side. No place like home. If it's questions that you've got, go the extra mile and die. The line, I know you know that I can't read your mind. Years can't fly by now, don't waste all your time. Cause I'll go the extra mile. Long road to the south side, 7 miles in my rearview mirror. I know what it felt like. My goals only getting clearer. East side to the west side. No place like home. If it's questions that you've got, go the extra mile and die. On the dash, got my laces tied. Long road, I don't waste no time. Break rules because fate decides. With the team and we chase the light. I make a move, fall down, shake it off. I hate to lose, bad branch, break it off. No room for negativity, praise and love. Prepare for deep part cause we're taking off. Take the mileage, traveling so far from home. Gathering knowledge, other connections. I put the time in to get everything I ever hoped for. It's a challenge and we all in. It's a better future that we go for. And even though these nights seem long, I know that I am never on my own. Know you've won the battle once you've grown. South side, 10 miles in my rearview mirror. I know what it felt like. My goals only getting clearer. East side to the west side. No place like home. If it's questions that you've got, go the extra mile and die. Long road to the south side, 10 miles in my rearview mirror. I know what it felt like. My goals only getting clearer. East side to the west side. No place like home. If it's questions that you've got, go the extra mile and die. Years can't fly by now, don't waste all your time. Cause I'll go the extra mile.
Yeah, we just stand here. Where is that over there? And later you come close to it. Yes. Yes.
Ronel Sewpaul, the degree committee here present has assessed the quality of your thesis and your defense in view of its positive verdict and taken into account your previous qualifications. The degree committee has decided to grant you the degree of doctor. Professor Crutzen is authorized to confirm upon you this academic distinction in accordance with Dutch university custom. I invite your supervisor to now take the floor.
Please all rise.
Starting with a question, do you promise to work in accordance with the principles of scientific integrity at all times, to be careful and honest, transparent, independent and responsible?
Yes, I do.
Then, by the authority vested upon us by law and in conformity with the decision of the committee here present, I hereby confer upon you, Ronel Sewpaul, the degree of doctor and grant you all rights attached to it by custom and by law. As evidence of this, I now present you with the degree certificate signed by the rector, the secretary and all the other members of the committee and affixed with the official seal of the university. Come down from the platform.
Please be seated.
Dear Ronel, dear Dr. Sewpaul, what a pleasure and a sense of satisfaction to address you as Dr. Sewpaul. Congratulations on this achievement and this academic milestone. I met you many years ago when you came to work at my Health Promotion Research and Development Unit in at the South African Medical Research Council in Pietermaritzburg. You had come from the University of KwaZulu-Natal, having successfully completed a BSc in Statistics and Economics and a Master's in Statistics at that same university. You hailed from a hard-working family in rural KwaZulu-Natal from a village named Howick, where your ancestors settled after being liberated from indentured labor, either to Dutch settlers or English settler farmers at the time. You are one of the first in your family to go to university because of the deprivations of apartheid and its attempt to hinder academic progress among black people in South Africa. From the start, you proved to be highly intelligent, diligent, and hard-working junior scientist. It was obvious, therefore, that you should embark on PhD studies. This was recognized by myself, Profs. Ken, Rob, and Bart. You were always willing to assist with biostatistical analysis for any of the scientists in the KwaZulu-Natal and Cape Town offices. In fact, so much so that you helped other people with their PhD analysis, delaying your entry into doctoral studies, often working under pressure and tight deadlines, but you never complained. Your conceptual and writing skills were very good, and as a consequence, you often got pulled into major studies in our research unit, doing work beyond the field of pure statistics and further delaying the point where you could embark on your own doctoral work. It was evident that you were destined to be an original research scientist in your own right, and not simply a statistician crunching the numbers, running the tables, and interpreting the data for others, important as those functions are in many research teams. You later moved to our Cape Town office and quickly became an indispensable part of our research unit and team. Much of the work we were doing was novel to South African science, and you clearly reveled in the process of making new discoveries in South African public health, employing statistical and research methodologies new to South African science, such as in the respondent-driven sampling, to access hard-to-reach populations in our out-of-school youth risk behavior study. You very quickly transitioned from a statistician to an intervention and implementation research scientist. You thrived in the world of behavioral science, health education, and health policy. In fact, while you were working on the PhD, you set aside unselfishly to provide evidence to our senior government ministers in South Africa during our various battles with the tobacco industry and its affiliates. During the COVID-19 pandemic, you showed up again when the country needed data very quickly on a daily basis for policy and interventions, where we were advising the President of South Africa's COVID Cabinet Committee on socio-behavioral responses to the COVID-19 pandemic. I can cite many instances of your commitment to promoting public health in South Africa and not just your own academic career. Meanwhile, you published many papers in international peer-reviewed journals and began to publish papers as a first author many years ago, long before your PhD studies, 80 to date, I think. So when I was awarded the Wellcome Trust and British MRC grant, which was a complex study conducted under very difficult environment, you were the best candidate to use this data to generate your PhD, but not necessarily in the field of pure biostatistics, or statistics for that matter. You had fully matured as a public health scientist in the field of health promotion and behavioral scientist engaged in designing, conducting, and analyzing this very difficult and complex study. I'm certain that you will progress to postdoctoral studies and continue to develop as a highly gifted biostatistician and behavioral science researcher. I'm also sure that you will continue to collaborate in health promotion and behavioral science and train many masters and doctoral students in the field in your own right. Go forward, Ronel. Be brave. There is so much ahead of you. Finally, to your dear mom, big congratulations to you. She has always been your rock. Thank you, Jason, for supporting your sister. Celebrate.
Dear Dr. Sewpaul, also on behalf of the Maastricht University and the Board of Deans of this university, it's a pleasure and an honor for me to congratulate you with this new degree of doctor. Your supervisor already expressed a lot of expectations for the future in research, but also in training and education. So we wish you all the best and a lot of success in your future career. Hereby, I will close this academic ceremony. We will move now to the central hall, where we will take a picture with the new doctor and, of course, also all the members of the degree committee. Hereby, I close this academic ceremony.